Chapter 12, Neuromuscular Blockade and Muscle Spasms. We'll skip over the terms and definitions and we'll cover them in the chapter. Skeletal muscles contract as a response to messages transmitted between peripheral nerves and muscles by neurotransmitters. Acetylcholine is the primary neurotransmitter that sends messages between nerve cells and muscle cells. The process begins with the release of acetylcholine from vesicles located in the motor neuron's end plate. The end plate is a projection extending off of the end of one of the branches of the motor neuron. The sole plate is the portion of the membrane of muscle cells that receive messages transmitted by motor neurons. Drugs that block nerve transmission between the motor end plate and skeletal muscle receptors are classified as peripheral acting muscle relaxants. Peripheral acting drugs are further classified according to their mechanism of action. They are classified as non-depolarizing competitive blockers and depolarizing blockers. Central acting muscle relaxants are direct acting agents that bind to and block calcium channels. Skeletal muscle relaxants that work by CNS depression are examples of central acting muscle relaxants. The release of acetylcholine produces skeletal muscle contraction. Calcium increases acetylcholine release. Drugs that decrease the release of acetylcholine or deplete acetylcholine levels in the neuron also cause skeletal muscle relaxation. Botulinum toxin and magnesium are examples of drugs that decrease the release of acetylcholine. Neuromuscular blocking agents have been used historically by indigenous peoples of South America. They are most commonly used as a general anesthesia for endotracheal intubation to facilitate mechanical ventilation. Endotracheal intubation is the process of inserting a tube into the trachea or windpipe. Botulinum toxin A, commonly known as Botox, is a neuromuscular blocking drug that is used in an outpatient setting. Its use is becoming widespread and it has been FDA approved for a variety of conditions, including temporary removal of wrinkles, treatment of excessive sweating, spasticity, uncontrollable blinking, and chronic migraines. To prevent possible injury or death, the United States Pharmacopoeia Interdisciplinary Safe Medication Use Expert Committee has compiled a list of recommendations for the safe use of neuromuscular blocking agents. So you can read through that list in box 12.1. Neuromuscular blocking drugs should always be dispensed with the auxiliary label warning, paralyzing agent. Use requires mechanical ventilating assistance. Depolarizing neuromuscular blockers are agonists at nicotinic receptors. They bind to ACH receptors where they produce sustained depolarization. Prolonged depolarization causes receptors to convert to their inactive state. Depolarization is the process where the cell undergoes a shift in electrical charge. Acetylcholine is the only depolarizing neuromuscular blocker that is currently available. Similar to ACH, it is rapidly inactivated by cholinesterase enzymes. Cholinesterase enzymes are synthesized in the liver and are responsible for the breakdown of succinylcholine. Most non-depolarizing neuromuscular blockers are competitive antagonists at pre-junctional and post-junctional receptors. At high doses, non-depolarizing drugs weaken neuromuscular transmission and reduce the action of acetylcholinesterase, the enzyme that reverses ACH-induced depolarization. So the ending curium and curonium are common endings for non-depolarizing muscular blockers. Most neuromuscular blocking drugs are poorly absorbed from the GI tract, so they're administered parenterally. Anaphylactic shock is an acute life-threatening allergic reaction that produces peripheral vasodilation, bronchospasms, laryngeal edema, and airway obstruction. Now we have the table that lists the neuromuscular blockers. So there's not many. Like we talked about earlier, the only depolarizing one is succinylcholine. We have quite a few non-depolarizing ones here. Drugs that reverse the effects of neuromuscular blockade must always be readily available anytime the drugs are administered. Anticholinesterase drugs inhibit the degradation of ACH by the enzyme acetylcholinesterase as the neuromuscular junction. This causes ACH to accumulate. Increasing ACH produces a skeletal muscle contraction, and anticholinesterase drugs are most effective after the process of spontaneous recovery from neuromuscular blocking drugs has begun. So we have drugs that reverse the effects of the neuromuscular blockade. Mestinon is one that you'll see both in the hospital and in retail pharmacy. And we have the summary of neuromuscular blocking drugs here. You can see all of them say keep refrigerated between 2 to 8 degrees Celsius, and they're all paralyzing agents. Neuromuscular blocking drugs are classified high alert by the Interdisciplinary Safe Medication Use Expert Committee of the USP because improper use can result in permanent injury, respiratory arrest, and death. Drug names that sound alike pose problems in dispensing regardless of the type of drug. Look-alike packaging is a problem that can be attributed to drug manufacturers as well as pharmacies dispensing drugs. Neuromuscular blocking drugs may be repackaged for unit of use in institutional settings. Infusion bags and syringes that have been prepared by the pharmacy can also look alike. Neuromuscular blocking drugs that have been administered in the place of vaccines, intravenous flush solutions, and antibiotics by mistake. So you can imagine what kind of disaster that is. Very life-threatening for many people. A pharmacy that fails to securely affix the label onto the infusion bag or syringe of a neuromuscular blocking drug has created a potential life-threatening situation for a patient. Additional medication errors occur from inaccurate sterile compounding, dispensing of incorrect drug concentrations, so like the strength in milligram or the percentage, and placing incorrect doses in automated dispensing machines. That right there is, I'm going to say, one of the biggest ways I've seen drug errors happening. Someone's filling up the automated dispensing machine, the wrong drug gets put in, or the wrong strength because they're right next to each other. If there's two drugs that are in the automated dispensing machine. So that can pose a lot of drug errors. And actually one time, me as a patient, I went to go take my medication that I've been taking for many years. And when I looked at it, when I dumped it in my hand to take it, I looked at it and noticed it was a different color, which when you get out into the pharmacy world, you'll see, if you already don't know, we have many different manufacturers, and sometimes the pharmacy has to change up what manufacturer they get just because they maybe can't get the other one. This one's cheaper. So for whatever reason, your pills can look different from time to time. Usually the pharmacy will put a little note on there. But in this case, they didn't. So I was like, you know what? I'm not going to take this right now. I'm going to go and check my on my computer and see if this is just a different manufacturer. So I type in the description of the medication and it comes up that it is Plavix. Now, Plavix is not what I was taking. That is an antiplatelet drug. So anyhow, I called the pharmacy to let them know, and it was late at night, and they were just like, I wasn't working there at the time, and they're just like, oh my gosh. And they looked in, the machine still had Plavix in it. And I was not the only one, of course, that had this drug error. So they had to contact every single person. They had to redispense prescriptions. So that is just a example of me as a patient experiencing a drug error in automated dispensing machines. So, what happened if I would have just taken it and not even thought about it? I would have been taking a heart medication for a month instead of my medication that I need. So it's just um one of those things that's just kind of happens from time to time. I can admit myself that I have put the wrong drug in the automated dispensing machine, maybe more than once for sure. But I know of a time where I accidentally poured in 40 milligrams of a drug in the 20 milligram spot. And I caught it right away because they were different colored tablets. One was white and one was like a pinkish color. So as soon as I poured in the pinkish color, I was like, oh God. And I wasn't, oh God, because obviously I was going to fix the mistake right then and there. It didn't get out to any patients, and it wouldn't have. But that was a really fun time sorting through all of those pills and having to have the automated dispensing machine. This was kind of an older machine. Have that completely dispense all the pills so you get all of them out. Yeah, it's a big process. So definitely want to make sure when you're filling that up, you're double checking things. Summary of drugs used to reverse the effects of neuromuscular blocking drugs. We have our warnings and storage conditions. So Enlon should be stable at room temperature. Mestinon, you should swallow whole, do not crush or chew. Protect from moisture. Spasticity is a debilitating motor disorder that affects up to 12 million people worldwide. Symptoms of spasticity are increased muscle tone, exaggerated tendon jerks, and hyperexcitability of the stretch reflex. Spasticity can also cause muscle weakness, decreased endurance, and reduction in the capacity to make voluntary muscle movements. It can be accompanied by pain. Stroke, spinal cord injuries, cerebral palsy, muscle trauma, like whiplash, multiple sclerosis, head injury, and metabolic diseases such as amyotrophic lateral sclerosis, which is ALS, Lou Gehrig's disease. You might remember the ALS challenge from a few years ago. These can all cause spasticity. Spinal cord injuries may produce muscle paralysis and loss of tendon reflexes in the region below the level of spinal cord injury immediately after the injury. So it is believed that spasticity develops because the neurons that branch out from the spinal cord to the muscles and tissues of the body grow new synapses that increase response to stretching of the muscle. Normal inhibitory control of sustained neuron firing is lost during the recovery period after spinal cord injury. What follows are unopposed motor neuron excitability. As muscle fibers atrophy, the number of sarcomeres decreases and connective tissue increases. Sarcomeres are units within muscle fibers responsible for muscle contraction. Spinal cord injuries also result in clonus, which is an involuntary rhythmic muscle contraction that produces involuntary flexing and relaxation of the feet and wrists. Strokes can cause a lesion to form in the brain or spinal cord, which results in unopposed motor neuron excitability by normal inhibitory mechanisms. Spasticity caused by cerebral palsy follows the same pathophysiological pathway as stroke and spinal cord injuries. Treatment is complicated because spasticity impairs effective muscle movement in some people with cerebral palsy and helps maintain posture, which makes walking easier in other people. In people who have ALS, upper motor neurons are damaged. Changes in the presynaptic membrane result in the release of ACH from its storage vesicle. This ultimately causes desensitization of motor nerves, muscle weakness, and cell death. So just a little tech note, the myelin sheath around neurons acts as an electrical insulator and increases the velocity of impulse transmission. Multiple sclerosis, which you'll hear referred to as MS, is an autoimmune disease that causes damage to myelinated nerves. Lesions damage nerves in the CNS and cause spasticity, pain, fatigue, dysfunction of the bladder and bowel, impotence, cognitive dysfunction, and changes in mood or depression. Nerve damage and symptoms get progressively worse over time. Spasticity is a symptom of upper motor neuron syndrome. The cause may be excess activity of neurotransmitters that carry excitatory messages such as acetylcholine and glutamate, or decreased activity or a deficiency of inhibitory transmitters such as GABA and glycine. Defective glycine receptors are associated with a rare disease that causes an exaggerated startle reflex called hypercaplexia. To manage spasticity, a variety of non-pharmaceutical treatments have been tried. Electrical stimulation, cryotherapy, cold packs, biofeedback, splinting, positioning, physical therapy, they've all been proposed. These non-drug therapies may support pharmacological treatments. Botulinum toxins type A and B are used for the treatment of cervical dystonia. Cervical dystonia is a painful condition in which the neck muscles contract involuntarily. The toxins have also been studied in the treatment of post-stroke spasticity and cerebral palsy. Only botulinum toxins type A are indicated for the treatment of blepharospasms. The toxin is injected locally to inhibit presynaptic release of ACH at the neuromuscular junction. This causes temporary paralysis in the muscles that have received the injection. The onset of effect begins 3 to 7 days after injections are administered and lasts from 3 to 6 months. Resistance develops with repeated use in injections, and the frequency of injection should be limited to no sooner than every 3 months. Dantrolene is indicated for the treatment of spasticity associated with spinal cord injuries, stroke and cerebral palsy, MS, and malignant hyperthermia. Malignant hyperthermia causes severe muscle contractions and fever. Dantrolene reduces spasticity by weakening hyperexcited muscles. It acts directly on contractile mechanisms and skeletal muscles. Dantrolene inhibits calcium-dependent excitation and contraction. The use of dantrolene in the treatment of some spastic conditions is limited because the drug produces muscle weakness. Muscle weakness is undesirable when treating spasticity associated with spinal cord injuries or ALS. So we have peripheral acting drugs used for the treatment of spasticity. Of course, dantrolene we just mentioned is available in a capsule and as an injection. And then the medication Ampra, delphampermine is an extended release tablet. Central acting skeletal muscle relaxants reduce spasticity by binding to receptor sites that control motor movement in the brain and spinal cord. The mechanism of action of these drugs is to enhance the actions of GABA, an inhibitory neurotransmitter, or to stimulate alpha-2 adrenergic receptors. Baclofen is indicated for the treatment of spasticity associated with spinal cord injuries and multiple sclerosis. Baclofen is structurally similar to the neurotransmitter GABA and is particularly useful in treatment of spasticity involved with the spinal cord injuries. So we have central acting drugs used to treat spasticity. So it's just baclofen under the brand names Gablofen and Lyrosol. We have a intrathecal injection and a tablet. Diazepam is classified as a central acting agent because its site of action, the brainstem and the spinal cord. It is the most commonly used benzodiazepine for the treatment of spasticity, and it is effective in treating hyperactive reflexes and painful muscle spasms. So diazepam is available as Diastat, which is the rectal gel they have an adult dose, but it's mostly for children with seizures. Diazepam intensol, which is the oral concentrate, and then Valium. Alpha-2 adrenergic agonists like tizanidine act like naturally occurring neurotransmitters to screen out unnecessary sensory messages that cause spasticity. They reduce muscle tone and the frequency of muscle spasms in people who have had spinal cord injuries, cerebral palsy, and stroke. Spasticity is reduced when drugs like tizanidine are administered because they prevent the release of excitatory neurotransmitters in the spinal cord and increase the actions of the inhibitory neurotransmitter glycine. So just a note, skeletal muscle relaxants should not be combined with alcohol. Alcohol increases the CNS depression produced by the skeletal muscle relaxant, causing excessive drowsiness and decreased alertness. So Xanaflex comes in capsules and tablets, and 2, 4, 6 milligrams for capsules and 2 and 4 in the tablets. Cyproheptadine is an antihistamine that is used in the treatment of spasticity associated with spinal cord injuries, as well as to treat baclofen withdrawal symptoms. However, this use is not approved by the FDA. So meaning it can be used for that, but the FDA has not said and approved like can be used for this. Its mechanism of action appears to be linked to its effects on the neurotransmitter serotonin, histamine, and ACH. Drugs that treat muscle strain include carisoprodol, cyclobenzaprine, metaxalone, and a few others. These skeletal muscle relaxants are central acting. However, the mechanism of action is unknown. It is believed their actions may be related to the sedative effects on the CNS. Skeletal muscle relaxants should be also used with non-pharmaceutical therapies such as rest, exercise, cryotherapy, cold therapy, heat, and physical therapy. So you can see actually a lot of these skeletal muscle relaxants are not available in Canada, which we don't really care about, but it's just kind of interesting. And we have all our dosage forms listed here. Then we have combination products, so like carisoprodol and aspirin, carisoprodol and aspirin and codeine, chlorzoxazone, acetaminophen and codeine. And now we have the summary of drugs used in the treatment of spasticity, which we've already went over, but we have some warning labels we'll talk about. So they obviously cause dizziness or drowsiness. If you've ever had to take one, you should probably know that. They definitely should not be taken with alcohol. You should not take one and go and drive ever. I mean, I guess if you're used to taking them and I wouldn't recommend it, but it can discolor your urine, the chlorzoxazone and methylcarbamol. The diazepam can be habit forming, of course, because it is a controlled substance, and we should not crush or chew cyclobenzaprine and orphanedrine extended release.